welcome everybody to the first new colloquium talk. So we've been off for the summer, so it's nice to get back to, getting everybody out there. First, we just have a little land acknowledgement. We wish to acknowledge this land on which the Fields Institute operates. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. And now I will turn things over to Jianhong Wu, who will introduce our speaker today.
Thank you, Ben. John does not need introduction to this group of audience. He's a global leader of established mathematical epidemiologists being providing the service for the US CDC and very professional can support to our modeling activities in Canada and globally. And many of you know John through a variety of activities at the Fields Institute and also organized by the Canadian mathematical modeling communities. John is almost everywhere in all the major events that we have been organizing. And John is in particular the plenary speaker of the first ever COVID-19 workshop held at the Fields Institute. That's probably the first ever globally on February 14th of 2020. So I'm very pleased on behalf of the Fields Institute and on behalf of this Mathematics for Public Health Network to have John as our first speaker of this 2022-2023 colloquium series. So with that, John Glasser from USCDC.
Thank you, Jian. Can you see my slides now?
Yes, it's not in full screen though.
Okay, I'll go to.
And is there any way to turn up your volume a little bit more, if possible?
Sure, I can do that. I can. It's almost all the way up now, but
yeah, much better.
Okay.
Thank you.
So thank you, Jianhong and all for this invitation. And I should, a couple of other things. I should say that I've been working on this project that I'll be talking about for more than a year. So some of you may have seen some of the slides before, and I apologize for that. But this is work that I've been doing with Zalon Fang and one of her students. Zalon is a long-term collaborator, and we've been working with two medical colleagues at CDC. And the project really has three pieces. The first, it's based really on serological surveys, and I'll show you a bit more about those in the next slide. But the first part was the analysis of those surveys to estimate parameters needed for transmission modeling. And we've done that, and I've spoken about that before. And at the time that we first did it, we were not sure whether antibodies decayed or not, but we now know that they do. And so we need, I'll show you the mathematics for this, but we lack the rates at this point to actually implement that. The second piece is to use seroprevalence to initialize, evaluate, and improve the accuracy of metapopulation modeling. And that has been accepted for this special issue of JTB devoted to SARS-CoV-2 modeling. And the third piece is to evaluate expressions for analytical expressions using parameters with which I'll show you this model fits the data beautifully without any fitting actually. We use those parameters to evaluate expressions for the reproduction numbers and quantities that can be derived from them. For example, the population unithreshold gradient and so on. And we've just submitted a manuscript and that we hope will be included in the special issue of Journal of Mathematical Biology in honor of our late colleague, Fred Brower. So this is a bit about these two surveys. We call them internally MathC and MathD. MathC is a survey based on commercial laboratory clients, people that go into into a commercial lab for purposes other than evaluating exposure to SARS-CoV-2. It's been running since mid-summer 2020, and in the form in which I'll be using it today, it's through the end of 2021, and then it shifted a bit, its emphasis more to children. The other survey is of blood donors, and it differs in that children aged less than 16 can't donate blood. All ages are represented in this one, and there's some other exclusions, but the strength of this survey is that it can detect vaccine as well as infection-induced antibodies, whereas the commercial lab one is just infection-induced antibodies. And there's a lot of information about these two surveys that were published. Observations reported to us periodically, biweekly, I think, but sampling was essentially continuous from mid-2020 to 21. And that's really important in terms of what we're able to do with this. We'd be lost if we just had a single cross-sectional serological survey, which is what we usually have in mathematical modeling. But here, the survey is serial, so we have time as well as age. And I should say, I think of antibodies as equivalent to immunity, but they're not. They're just evidence of an adaptive immune response, but they're really only an easily measured proxy. They're a part of the story, but not the whole story. And the last bullet, refers to this, and it's an important point that neither of these surveys was a random sample, but they're both saying the same thing. This is the immune profile during September 2021. And you can see that both surveys are saying the same thing. You see the children in the commercial lab survey, but you can both of them are seeing the contacts between parents and children are evident in those elevated infections among parents or adults with young children. This is the commercial lab survey showing you what I just did, but this is overall. And this makes the point that I made before, that it's essentially ongoing. There was a hiatus during the summer of 2020, but it resumed, and then it's changed its focus a little bit. But the first thing we did was to create immune profiles from these data via bivariate logistic regression, with age on one axis and time on the other, both represented by polynomials. And these are saturated statistical models, so because those two variables are related, all of the interactions are present. We can slice through those surfaces at arbitrary times to provide initial conditions for transmission modeling and also observations with which predictions could be compared. I'll show you that a bit. And third, they also provide the wherewithal for calculating forces or hazard rates of infection that together with constant rates permit evaluation of the probability of infection on contact. And this is where the importance of the serial nature of these surveys comes into play. If we just had a cross-sectional survey and we calculated the force of infection in the usual way, the derivatives would be negative beyond here. So we'd be stuck, but we have time. So almost everything else needed for transmission modeling can be changed from the literature, informed opinion, and I'll explain what can't be gotten from the literature. But it's an important point. There's no fitting here. All of the parameter values is from the literature. So here's that service I was talking about. So this is age and this is time. And these are just slices mid-month from August 2020 to October 2021. So, with regard to analysis, most infected people have antibodies to nucleocapsid as well as spike proteins, whereas vaccinated people have only antibodies to spike. And so consequently, we can't tell if infected people have also been vaccinated. And so we let the proportion susceptible, and we both age and time are discrete for reasons I could talk about if folks are interested. But we let that be the complement of the proportion that are immune by virtue of either infection, vaccination, or both. And then if we let lambda ij and chi ij denote the rates of infection and immunization in the appropriate intervals of age and time, the susceptibles at a given age and a given time are equal to the susceptibles at the same age, previous time, times the probability that they're having escape infection and vaccination. And so that leads to this expression here for the sum of these two things. And we can write we do know the people who've been only vaccinated, so we can write the vaccination rates this way and obtain the force of infection by difference between the last two equations. If we don't have vaccination, it's a simpler problem, but same idea. So here's a plot of the force of infection as a function of age and time. And in the US, we began vaccinating mid-December. And you'll see that in a bit on the next slide, I think, but that's responsible for the change in the surface. Now, I mentioned that we can't tell if people if infected people have also been vaccinated, but this is based on a subset of people in this survey of blood donors, and we asked them about their vaccination status. And so you can see that the numbers only vaccinated actually decline over time because they're being, only infected decline over time because they're being vaccinated. So these are the people who are both infected and vaccinated. And then these are the vaccinees. It may be that blood donors, or I'll get to this a little later, may be disproportionately vaccinated, but in any case, this is what the age profile looks like. We began by vaccinating healthcare workers and other essential workers, and then moved quickly to people who are immunocompromised by virtue of age or whatever. And so this is what the immune profile due to immunization in the U.S. looks like. Okay, the attack rates, we calculate them as product of probabilities of remaining susceptible at age and force of infection, and at any age, the probability of being susceptible at a particular time is e to minus the integral of these two functions, infection and vaccination, and we can integrate from either from birth or beginning of the epidemic or whatever. So I said that this is, the complement is the cumulative probability of being immune. So if we take the derivative, it looks like this, and we'll write it this way. But that equals the force of infection times the proportion susceptible. And or numbers of susceptible if we multiply them. And so these are the numbers of new infections, commonly called attack rates, and these are the numbers of new immunizations. And we're not going to use that at the moment, but I'll ask you to remember how we calculated that a bit further on. So this is what the attack rates look like at three different times. These are, they're Christian holiday. Well, this is Thanksgiving in the U.S. This is Christmas, and this is Ash Wednesday. And you can see that vaccination, the green one, is starting to dip down among older people. So vaccination has started to reduce the attack rate among that age group. But where we are now is we have the force of infection, and we have the attack rates, and we need the contact rates and with whom, the mixing matrix, and then we'll have a number of equations, each with one unknown, and that we can solve for. And this is the information over here is a bit about translating this derivative into this ratio and the conditions under which one can do that. So a bit about the contact rates. We use data from Prem et al., which are synthetic, and they use various bits of information from individual countries to develop these matrices based on the study in 8 European countries that you all know about. They were intended for use in countries where contact studies hadn't been developed, hadn't been conducted. They have in the U.S., but the results are not entirely consistent. So we use these synthetic ones. This is what they look like. Most of the contacts are on the main diagonal, and children, and particularly adolescents, have much higher contact rates than anyone else. Most of them move with each other or others who are close to them in age. If you look hard, you can see the contacts between parents and children in these off diagonals. but if we sum the rows, we get the marginal contact rates regardless of with whom, and then we divide the elements by the marginal contact rates to get the proportion. So this is the A in that previous equation, and this is the Cij. So we have everything we need now and can solve for the betas, and those are shown here at 3 time periods. And again, vaccination has started to affect the probability of infection on contact a little bit, but what we use the ones from Thanksgiving in the transmission modeling I'll describe. We chose assays that are stable, but could have underestimated the force of infection and attack rates, which may have affected the probability of infection on contact. And I'll show you that the equations that are required to compensate for weighting, but we haven't really evaluated them because, as I said at the outset, they require the rates at which vaccine and infection-induced antibodies decay, and that's what one of the serological surveys is focused on now, the blood donor survey. They're now, instead of being cross-sectional, it's a longitudinal survey based on repeat blood donors, and it will provide those data and inform possible changes to our transmission models, which, as I'll show you, allows boosting but doesn't distinguish immunity from 2 vaccine doses and infection. So this is the math required to incorporate weighing. It's a discrete time SIRV system, and we can, from the V equation, based for the fractions, and from the V equation we can calculate the vaccination rates, which require the rate at which vaccine-induced immunity declines. But given that, we can from the S equation, we can calculate the force of infection, but that requires both those vaccine-induced immunity waning rates and naturally acquired immunity waning rates. But so we're ready, but we don't have those rates yet. But once we have them, we can go through the calculations I've just described and see what difference it makes, if any. So on to the second part. We've done some previous work in Jamaica and in Argentina, where the non-pharmaceutical interventions were a bit more homogeneous. But in the U.S., they were time varying, really heterogeneous from one jurisdiction to another, and of unknown efficacy and compliance. And I think, as everyone in this audience knows, this makes modeling difficult, but it is the best way to assess the indirect effects of interventions, and by that I mean the others that averted infections don't cause, whose magnitude in our experience can be comparable to, if not exceed, that of direct effects. And so that's why we do it. That's why we all do it. We at the time, I guess I wrote this slide, we'd begun initializing a biologically realistic model at arbitrary times, comparing predictions to observations at other arbitrary times, identifying disparities and diagnosing and remedying their causes insofar as possible. Because we're using serological observations for all of these purposes to initialize and evaluate, by which most infections and vaccinations are detected, underreporting is not as much of a problem as it otherwise could be. I mean, most transmission modelers are trying to match reports. We're not trying to match reports. We're trying to match what actually happened. And once we're satisfied with the accuracy of predictions during one epoch, and we'll divide the epochs into particular suites of interventions or variants, we'll model the next epoch. And I'll show you 2 of them. The first is September to Christmas 2020, and that's when the wild type is circulating and non-pharmaceutical interventions were the only things available. And then the period from Christmas to Easter or early April, when the alpha variant arose and became dominant, and we began vaccinating. So the goals of this part of the project were to develop an objective approach for diagnosing the causes of disparate predictions, inevitable disparate predictions, and also a reliable model for evaluating interventions in future pandemics caused by respiratory pathogens. So this is a model. It's a modified SEIR model. We've taken the I compartment and we've expanded it into asymptomatics, symptomatics, and pre-symptomatics, because you're most infectious a few days before and after the onset of symptoms. And then most people recover. Some require hospitalization, and there are deaths among those hospitalized and others who don't die in hospital. There's also a 2-dose vaccination program. There's the first dose, second dose is here. So we're treating full vaccination and recovery from infection as equivalent. This model allows for waning and boosting, although boosting had not begun by early April 2021. And in our models, host populations are stratified, and this particular one is stratified by both age and location. There are 16 age classes and 51 locations, so there are 816 groups. So, as again, most of you know, metapopulation modeling requires realistic mixing. I mean, it's only as good as the mixing. Yeah, I just said this. Within locations, contacts are around an increasing function of population density, and I'll talk about that on the next slide. Between locations, they decline with distance at age-specific rates that are shown here. And these are calculated, and the algebra for that calculated based on the PREM data, and the algebra for that is in this reference. And what this shows is they're pretty much constant throughout life, perhaps a little bit, so they're sort of declining at these rates. So the rates here are decline are lowest, and they're declining fastest among older people, which means that the spatial range of contacts among older people is smaller than that among most others, and I hope that makes sense. This is now within, that's between, this is within locations. We want that to be some function of population density, but Washington, D.C. is almost 11,000 times as densely populated as Alaska, and so it can't be a linear function. But the natural log of density, I get used to this mathematical uses. Anyway, it's natural. Is a saturating function of density. And what we do is we take the jurisdiction's log densities and we divide those by the log density for the entire United States. So this is the ratio of the log densities of individual states and Washington, D.C. and the U.S. And so you can see that Alaska's an outlier, but otherwise, and D.C. is about a little over twice the U.S. average, but most jurisdictions are between 1.5 and 1.5 times the average. I mentioned earlier that we really couldn't explicitly model NPIs in 51 different jurisdictions. They were just doing too many different kinds of things. We did do that in Jamaica and Argentina and so on. But what we've done is to use the Oxford stringency indices, which I understand that folks at Public Health Canada have been doing as well. So this is for the entire U.S. This is an estimate of governmental efforts to mitigate the pandemic, and those ramped up to some point in March and then oscillated sort of thereafter. What we did was divide by 100 and take the complement of that and then fit a high order polynomial. And so we're going to multiply those contacts, overall contacts, and we're not going to do this for the whole U.S. We're going to do it by jurisdiction. Are going to be changing with time. That's one of the time varying parameters in this model. The initial conditions are pretty much conventional. Most of them are based on the zero prevalence at the day when we began the simulations or a few days before to populate the various I classes. But there are a couple of key literatures that we consulted. In particular, all my references are at the end, but in particular this paper by Clark et al. And Levin et al. The forced infection in this model is similar to the one that we looked at before, but there are four I classes, four infectious classes, and the 8 is just infectiousness relative to the symptomatic people. The size are functions by which non-pharmaceutical interventions reduce susceptibility if you're susceptible, and infectiousness if you're infectious. And we got the C's are compliance. We got those from a YouGov survey. It doesn't vary much over age, but does. And the efficacies are the one thing that one can't get from the literature. I mean, there's plenty of estimates in the literature, but they're all over the place. And I mean, I think if you look at how people, just think about masks, let alone distance apart. But you know, masks come in all, some in 95. My own mask is my stuff's made, it's homemade, but I think I wear it properly. Most people don't. It's hanging under that, they're just, not only is it unknown, but unknowable. And so what we did was to fit that, if you will. That's the only parameter that we've adjusted to get the model predictions to resemble the observations. And we came up with a number that folks who study masks tell us is not unreasonable. This particular time, these are the infectious states, and these are the others, left and right, respectively. And this is a time in the fall when infections were increasing, and then in spring they were decreasing, possibly due to vaccination. But so during fall, we estimated the efficacy of these NPIs we just mentioned against wild type, and then conditional on that, in spring we evaluate the impact of vaccination during the ascent of the alpha variant. And on the next slide, the observations I'm going to show you are sums of products of age and state-specific proportions immune, that is surfaces like the one I illustrated before at the beginning, just for the entire U.S. on Christmas or Easter, and products of those and the jurisdiction populations. Predictions are sums by age group and state of those temporarily immune, that's the removed class, by virtue of recent infection or vaccination from the model. So this is a little bit complicated. A and C are Christmas, and B and D are Easter, and anti-N are the observations, and moved is the model predictions. So you can see, first of all, the model fits today pretty well with just that one adjustment. And you can also see that vaccination didn't really have much effect by Christmas. If you look by Easter, though, again, the model fits the anti-N pretty well, but there's a discrepancy between the anti-S or anti-N that is which should correspond to the removed class. The blood donor survey indicates a larger number immune than the model predicts. And so we spent some time worrying about that. I mean, that was the point of this part of the study, was to try to figure out what's causing the discrepancies, and this is clearly a discrepancy. Let me talk a little bit about how we model vaccination. In the work just described, we obtained age and location specific numbers susceptible and vaccinated with one dose at the beginning of each week by simulation. Calculated proportions vaccinated from reported first and second doses administered that week. Jurisdictions report to the CDC how many doses they've administered by age and dose. And then we simulate with the corresponding vaccination rates and repeat the next week. So that's where those, that's how I modeled vaccination during that second period. In the work I'm going to show you, motivated by our analytical results, susceptible people move directly to the removed class at weekly immunization rates now, estimated from the serological survey of blood donors, the same way that we estimated the force of infection. And if we do that, you can see that we get an awful lot closer to the blood donor survey. And so what that suggests is one of two things: either doses administered are underreported, or blood donors are disproportionately vaccinated. They're particularly health conscious, and so I think both of them are probably true, and so it may well be that the truth lies somewhere in between here, and we're not exactly sure where at this point, but that's where we are. This is repetitious, but it's important to note while the current model allows boosting of vaccinated or previously infected people considers infection and vaccination-induced immunity to be equivalent, and we don't now know that it's not, but that should be fine for these two epochs. But insofar as waning rates depend on how immunity is acquired, if rates differ for those with infection and vaccination-induced immunity. Another model is going to be needed soon to keep pace with current understanding of the biology of this disease. I mean, this is not a new thing for us. Our first model didn't have vaccination at all, and then we added 1 dose, and then we added 2 doses, and then we added boosting. So this is just another step in that process. And our medical colleagues are thinking about a proposal to distinguish infection, vaccination, and hybrid immunity. But to consider the various possible sequences equivalent, so it doesn't matter if you're infected or vaccinated first, at least in this model. So we've drawn out their diagram, and they're thinking about it. But meanwhile, we've analyzed the model that I've been talking about. So this is the third part then of the study. And it's based on the observation during the pandemic, at least at CDC, renewal equation estimates time-varying effective reproduction numbers were useful to policymakers in evaluating the need for and impact of mitigation measures. And so what we're going to do is try to illustrate the public health utility of analytical results that derive from the metapopulation model. And these include sub and overall or metapopulation, basic and effective reproduction numbers, subpopulation contributions, and prevalence associated with the metapopulation numbers, contributions by infectious state, the gradient with respect to all possible vaccination rates before and after vaccination began. So a whole bunch of different analytical results. And we've also, motivated by those, done some further simulations. So before we get into the metapopulation part, if we set the if we consider a homogeneous population, in which, however, there are two kinds of interventions. Not only are there non-pharmaceutical interventions, but there's also vaccination. We can derive an expression for the population immunity threshold, and it looks like the familiar one minus 1 of R naught, but it has these other terms that these are the psi functions, or the reductions in susceptibility and infectiousness by virtue of non-pharmaceutical interventions, the epsilons are efficacies, and the chi's are vaccination rates, and the omegas are waning rates. It has all those things in it. You can see that what is perhaps perfectly obvious to us, but not others, is the more non-pharmaceutical interventions contribute, the lower the vaccination coverage need be to attain the population immunity threshold. So that's very interesting, and I think it's important. But what public health policymakers want to know is, they don't just have a home and 2 interventions. They often have more than 2 interventions, and they have heterogeneous populations. And in this model, the 800, as I said, 16 groups, and what they really want to know is, how do we allocate these our resources, and non-pharmaceutical interventions and our vaccination. So we'll get to that. But first, let me show you. These are subpopulation effective reproduction numbers, and so remember there are 4 infectious states. So these are the asymptomatics. B is the symptomatics. C is the pre-symptomatics. I'm sorry. B is pre-symptomatic. C is symptomatics, and D are hospitalized people. The numbers on the y-axis are very different. In our models, most of the asymptomatic infections are young people. The probabilities decline with age. I know you can't tell which states these are, but there are 816 numbers here. I think this is Washington, D.C., but on Christmas. But the symptomatics are mostly older people, and so the pre-symptomatics and symptomatics and hospitalized people all have this kind of shape. So those are the contributions by infectious state. What I'm showing you here are, in the first row, are the individual basic numbers on the left, and the contributions to the metapopulation number on the right. And the second row are the effective reproduction numbers. So the C is a composite of what the four slides I just showed you. Which is sort of why this peak occurs here. In our parameterization, symptomatic people are more infectious than asymptomatic people, but to me, what's really interesting about this is these are the individual numbers, as I said, but these are the contributions to the metapopulation numbers. So the difference between these two is mixing. Mixing is terribly important. I mean, you see the adolescents coming out here. Not only are they having the highest contact rates, but their contacts don't fall off the distance as fast as others do. I think I said most of this before, but in terms of vaccination strategy in the U.S., the objectives were, first of all, protect healthcare and other essential workers, then people at risk of serious illness, hospitalization, or death, and by virtue of age, comorbidities, medications, and then on to progressively younger and healthier ones. But policymakers think of this, population immunity, herd immunity threshold. They think of this in the context of protecting people for whom vaccination is contraindicated. But one might actually want to do this for other reasons. I mean, for example, we put an awful lot of vaccine into elderly people, and they don't respond as well to novel antigens as do younger ones. And so it's also possible to protect elderly people indirectly, and policymakers don't tend to think about that. And that's one thing that we can cause them to think about as modelers. So let me try to answer this question. What strategy would optimally protect people indirectly? Well, we suggested the gradient of the metapopulation effective reproduction number with respect to parameters by which interventions are represented. And in our work so far, we've looked at vaccination rates. But for those of you who are not familiar with the gradient's a multivariate partial derivative of, in this case, the effective reproduction number with respect to all possible vaccination rates. And a topographic analogy for minus the gradient is the route of steepest descent. If you're up on a ridge line and an electrical storm a thunderstorm is approaching, what do? You calculate the gradient, because that's going to tell you how to get down fastest. And we've done this calculation with and without constraint, and with regard to vaccination, the constraint is some limited number of doses that might be available to use for a supplemental vaccination program, or whatever. And we've since used it to identify optimal vaccination pre-pandemic when we were working in China on vaccine-preventable diseases. We've used it to identify optimal strategies for measles and rubella. So as you all know, the gradient's a vector-valued quantity. This is pre-vaccination. The elephant in the room in our room is California, and then Florida, Texas, New Jersey. I don't know if you can read these things, but the states that are huge and densely populated. This is the direction. So again, I think it's probably California, Florida, Washington, D.C., and so on. So that's before vaccination. So this tells you, if you're a policymaker, where do you put your resources? Well, these are the important populations, and these are the important age groups. This is after vaccination. This is the first, second, third, and fourth weeks of January in 2 jurisdictions. This is California. This is Washington, D.C., and just Washington, D.C. has an unusual age distribution, but all the jurisdictions show the same thing. So this first week, second week, third week, fourth week. As we vaccinated these older people, the gradient comes down in the older age group, but it stays where we're not vaccinating. We wouldn't vaccinate these adolescents until fall, much later. Well, motivated by that, we did some experiments, and of course, as you know, the essence of any experiment is that only one factor is varied at a time to reduce its impact conditional on others. And so all else equal amounts to holding non-pharmaceutical interventions and available vaccine doses constant in all locations during each period. So using immunization rates from the survey blood donors and numbers susceptible when vaccination began, both by age and location, we calculated the numbers of doses administered and numbers susceptible by age and location each week. And then using those numbers, we calculated uniform, this is our simulations deterministic. If they were stochastic, these would be random, and gradient vaccination rates to compare with the actual ones. And to make the gradient calculations go a bit faster, we reduced the number of age classes from 16 to 6. These are the asymptomatic infections, symptomatic infections, hospitalized infections, and deaths under the 3 strategies: the actual strategy in yellow, the gradient in brown, and uniform in blue. So if you look at the asymptomatic infections, you see that, and so this is the absolute difference between these vaccination strategies and no vaccination. So you can see the absolute difference is greatest for the gradient, for at least for younger age groups. The actual strategy doesn't do very well through those, and the random strategy is kind of intermediate. But if you look up here in the symptomatic infections and the hospitalized infections and the deaths, you see a very different picture. The actual strategy reduced symptomatic infections, hospitalizations, and deaths among older people, which is where they occur, much better than the gradient, better than the random strategy. And I think that's really, this is the heading of this slide really is the take-home message that what's optimal really depends on the policy goal. And I tend to forget that sometimes, frankly. But so the model whose immunization rates were calculated via serology versus reported doses administered indicates that the actual strategy would have attained policy goals, which were to reduce symptomatic infections, hospitalizations, and deaths, better than that specified by the gradient, which would have reduced the effective reproduction number most expeditiously. And that's true at least during the first few months of 2021. It may that story may actually change later on, but I think it's nice as a modeler to be able to say to, especially one who works at public health agency, to be able to say to policymakers what you did was right, given that goal. And this may be my last slide. I've just got a couple of slides of references, and when I stop talking and let you ask me questions.
Thank you, John. Any